Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Sleep medicine has been intertwined with technology since we were able to read studies remotely and monitor PAP adherence. Unsurprisingly, the field is full of innovators and has caught the attention of big tech players like Google and Apple. How will our field continue to be disrupted? How can this disruption lead to better sleep for our patients? How will it change the day-to-day practice of sleep medicine? Here today are Steve Van Hout, the Executive Director of the AASM, and Dr. David White, Professor of Medicine part-time, Harvard Medical School. They are here on this bonus episode to offer a sneak peek of the upcoming Sleep Disruptors course this November 14th and 15th in Austin, Texas. Thanks for being here.
Thanks for having me.
Okay, so Steve, in full transparency, I really wanted Azizi here because he is the chair and has been the chair of Disruptors for like the last 2 or 3 times. But he's in Europe, so I appreciate you being willing to sort of be second chair.
Yep. I mean, you definitely got the second chair. Azizi is amazing. He's such a character. He is such a great leader for Disruptors, and he brings a lot of energy to the meeting. I'm sorry Azizi wasn't able to speak to you and get the word out about Disruptors, but I'll try my best.
Yeah, I do love speaking with him. I think we chatted about, I don't even remember what it was, years ago, and it was like 90 minutes. It was like, I think all of our spouses were trying to pull us off the phone. But I love how he's energetic, but I feel like he also is able to drill down, right? Like he's going to do a lot of Q&A after the session, right?
Yes. Yeah. He really likes to get to know the speaker and make sure everyone understands the speakers and definitely opens the floor up for people to ask questions.
And I feel like sometimes the questions he asks are like questions I didn't know I had. And then it'll continue. Then I'll start sort of like, I'll take it and run and I'll think of other things that I'm curious about, right? Because I think he's really good at sort of harnessing that curiosity and making you feel, at least he always makes me feel like it's okay not to have all the answers. And it is okay to ask questions, right? And to feed that natural curiosity.
He was born to be kind of leading these type of events. So yes, you're right. He is great at facilitating, discussion between the speakers and the attendees, and it's going to be amazing. This is his 3rd time doing it, and there's a reason he keeps getting asked to come back.
So should I be insulted? Because I'm pretty sure I was chair of the first one.
Come on. You were the chair of the first one, and very proud of everything you came to the meeting. That was not meant to insult you. I think
I'm just teasing.
Both know, you know your hands full and a lot of different stuff that I've asked you to work on, and we've talked about that you are my science experiment. Was
guinea pig, I think, was the official.
Guinea pig. There you go. Yeah.
I feel like I need a T-shirt or like a plaque that says like official ASM guinea pig.
Yeah. But hey, you will be able to participate at this year's Disruptors. We do have you as a speaker. Really excited. Talking Sleep. The podcast is coming to Disruptors. So we are going to have Talking Sleep live, the very first time I think that we've ever done a live podcast, and it should be really exciting. And we are excited to have you there for that. And then I'm assuming you're going to be speaking to a number of the speakers that we have in the event.
I have my eye on at least 3 of them. And of course, I've been bugging Dennis too, because I've been bugging him for probably 5 years to be a guest. And I've not succeeded yet. I know. I'm like, come on, Dennis, don't leave me hanging. And there's at least 3 of the presenters that I'm so intrigued with. But I'll be honest with you, it'll be so weird doing it without like one dog under me and one dog on the couch.
Yeah, sorry. We don't have that there.
So Steve, you came up with the idea of Disruptors years ago. How is that different from the other AASM meeting like Trends or like the June sleep meeting?
Sleep Medicine Disruptors is really unlike any of our other meetings. It has its own vibe. It's a lot more, we'll say, not as traditional as the others. We're willing to take more chances. So I'd say the other events that we offer are really talking about today, like what to expect today, how to handle different things today. What makes Disruptors unique is it really focuses on the future. What is coming up? What are things that we should be aware of or even start to prepare for? So it really is about innovation and how we might adapt or need to start adapting to future changes that, in the end, could create disruption for either you as a clinician or the field of sleep medicine.
So is that what you kind of mean by disruptors? I mean, I hear this term tossed around a lot. So what do you mean when you talk about disruptors?
So my background is actually in technology.
Mm.
So I've been talking about disruption and in different innovation type of stuff for quite some time, even before I was executive director. So I don't look at disruption or disruptors as like a negative type of a connotation to it. I just look at it as a shift. Things are changing, and it's enough of a shift that we really need to do something about it. So I look at disruptors as essentially innovation that will drive the future.
So is this course meant for clinician or for industry folks? You know, are you kind of hoping to bring together like the docs and the technology people and the researchers and the investors?
Yeah, it's really designed to bring together a broad group. The I would guess I could say the initial target audience would be clinicians for our members, so they are prepared for disruption that will occur. But there's definitely still a lot of interest from outsiders. So we often get different researchers, investors, people who are more business minded, and it's not uncommon to have those groups there as well. I remember at the last Disruptors, we had a lot of people talking about business ideas and what are new type of offerings that we could deploy and experiment with. So it's really a diverse group. It's definitely people who I feel are a little more comfortable with the idea of change. But this is not designed to be scary to people who are resistant or uncomfortable with innovation and disruption. It really is designed to hopefully make people more comfortable and more willing to accept the changes that we feel are coming.
Do you know what I kind of remember and kind of loved about this course is the keynote speakers were kind of aspirational, right? And talked about these big grandiose ideas that were not specific to sleep. But then sort of throughout the course, you would start to get more sort of actionable information that was more pertinent to sort of clinical practice. So I thought that was kind of cool to go from sort of big, broad ideas to, okay, well, that's all well and good, but this is how you implement and these are the things you should consider.
Yeah, I mean it's definitely set up that way. Of all of our meetings, there's definitely a lot more, we'll call them outsiders at this meeting in terms of speakers. So we do bring in hopefully names that might be recognized and to do the keynote, and they are designed to be more thought provoking, more broader discussions. Most of the time, not even specifically about sleep. So for this Disruptors, we do have two keynote speakers. One of them is the former CEO of Kaiser Permanente, Robert Pearl, and he is somebody who really understands how the healthcare system works and is really somebody who's now focusing on how technology might impact healthcare. He recently wrote a book called ChatGPT MD, a really interesting book where he's actually exploring how generative AI is going to play out in healthcare, how clinicians can implement it within their practices. So, he's going to be talking about the state of healthcare, but then also he definitely is going to be talking about how AI can be integrated into healthcare, and it's going to be extremely exciting to hear him and hear his perspective on what I think is a very important topic. We have one other keynote speaker this year, Natalie Nixon. Natalie Nixon is kind of a unique speaker. She brings the concept of creativity and how creativity is used in really your day-to-day life. What we want to do at Disruptors is really challenge your mindset. So in the past, we've done talks on growth mindsets, on moonshot thinking. And we thought this year it'd be interesting to really look at creativity. And we were thinking more about improvisation. There's a lot of things that are happening that we're just, we feel like we have to improvise on. So she's going to bring that perspective of how we can utilize creativity in our innovations and how we approach disruption. So really excited to have her also as one of our keynote speakers.
And we've kind of lived that, haven't we? You know, between COVID and the recall, I think we all had to come up with creative solutions. So that's probably well timed.
Yeah, no, I think it is. As we were planning for this year's Disruptors, this idea of agility and having to react quickly kept coming to our mind. And that's really where we thought, this ultimately is about improv. It's improvisation and having just some additional training on how to adapt quickly and be agile. We thought was very appropriate given where the state of technology and really the kind of the rapid increase in innovation that's occurring. And we thought that was be a tremendous topic.
So one of the guests is Dr. David White, who will be talking about pharmacotherapy for obstructive sleep apnea. So he actually sat down with us earlier to talk about the data to date and what he will be able to share in November. Hey, Dr. White, thanks for sitting down with us to tell us all about your upcoming presentation. So I was really excited to hear about all of these new medications for obstructive sleep apnea. So where do you want to start?
We probably ought to start with the nearest term agent that's out there, which is Apnamed's AD109.
Yeah, let's start with that one.
AD109 is a combination of atomoxetine, a norepinephrine reuptake inhibitor, and R-oxybutynin, which is the R isomer of the anticholinergic oxybutynin. And these drugs were selected based on rat work that Richard Horner did, which would suggest that atomoxetine ought to turn on upper airway muscle activity during non-REM sleep, and the anticholinergic R-oxybutynin ought to turn up the muscle activity during REM sleep. So it was sort of a natural combination. And that actually evolved out of our lab in Boston. We ran a quick study in about 20 people, and there was a huge effect, and that led to the evolution of the company Apnamed, which sort of spun out this, and they're well along. They did a bunch of very small studies, and they did a substantial phase 2 study, which showed very positive results. And now they've put out top line results on their 2 phase 3 studies. The FDA required 2 studies, one of 6 months duration, the other of 1 year duration. Think about these are placebo-controlled, randomized trials for 6 months and a year. So essentially, people go on placebo for a year, not knowing it, obviously. But anyway, both those studies have concluded, and they have given us sort of top-line data through press releases, which really just tell us what it did to the AHI. I mean, one study, the first one, the 6-month study, had a 55% reduction in AHI-4, and the longer study had about a 46% reduction. I will say that the primary outcome for both studies was the 6-month data. So even when they're reporting for the longer study, they're reporting the 6-month data. And the rest of it was really, they look at efficacy there, but it was more of a safety outcome than an efficacy study. So both those, it had improvements in things like hypoxic burden, and they gave us a little information, like 25% of people got down to an AHI less than 5. They say we don't know where that group of people started, but they got down to that. And so, I mean, from an AHI point of view, it's very positive. They gave us no information whatsoever about subjective improvements, side effects, dropout rates, things like that. So, that's all going to have to be forthcoming. But from a purely AHI perspective, I mean, you're talking about roughly a 50% reduction in AHI, across and this went through the whole gamut from AHI greater than 5 all the way to infinity.
Oh, wow.
Okay, so now
Super severe. Yeah.
they controlled BMI. You couldn't have a BMI over about 40 in men and about 42 in women, but they did not control for AHI. So, so it has a full range of that. So that's in the works. We ought to have, by the time the Disruptors presentation occurs, we'll have all that data, or at least all they're going to share. And so we ought to be very interesting. We ought to have a pretty good handle on both patient-reported outcomes and side effects and one thing and another. And so that drug is assuming it gets through FDA, and the plan is that they're going to submit that in roughly January, February, certainly Q1 2026 timeframe. And the average time to get through the FDA these days for a new drug is about 8 months.
Okay.
So we're probably looking at sometime sort of Q3, 4, 2026 that this may go on the market and become commercially available.
Well, that's super exciting, right? That's a pretty impressive reduction in AHI.
No, it is. It is. It's as good as anything except CPAP, and CPAP has it works best, but has its obvious limitations as well.
I didn't realize the upper end of BMI. I mean, it's still pretty generous.
It is. No, I mean, it's more generous than like Inspire started with. When they went out, started with 32, and they're now trying to do it. People recommend with dental appliances, you don't put it into the really obese. Now, I have not seen their numbers based on BMI, okay, at all. So we don't know whether that was a problem. The phase 2 study that they published, although they didn't give specific numbers, they said that BMI was not really a predictor. But in that study, they didn't go above. They did not. I'm trying to think on that study. I don't think they went above 35.
Okay.
And so, but now they've gone higher than that. So, I mean, obviously the muscles can keep the airway open when we're awake without difficulty, no matter how obese it may be. And so, how much you can turn these muscles up with a drug is unclear at this time, but the potential's there to be able to, to do a lot. So it'll be very interesting to see and how the FDA looks at it and whether they put out some restrictions on it one way or the other, like they did, say, with Inspire, or the insurance companies have some restrictions like that. But time will tell. I mean, we're going to have to dig in deep into these new data. Yeah. And these new data, they're huge studies. I mean, relatively speaking to the sleep apnea world. I mean, each study had about 650 patients.
Oh, wow.
So it was each study required about 70 centers.
Holy moly.
To run it. So it was in the sleep apnea world, it was, one of the biggest studies ever.
So what else I'm really curious about is the cannabis derivative one, the Incanex one?
Yeah. Incanex has got a combination of dronabinol and acetazolamide. Okay, they've combined a THC compound with a carbonic anhydrase inhibitor. And they just published a paper recently, and I'm not going to go into it all right now, but it's interesting. And what we'll have to sort of work out in terms of interpreting that data is that data better than the data with just a carbonic anhydrase inhibitor alone? And is dronabinol adding anything to the acetazolamide? Is it getting a better effect either on sleep itself, or on the AHI? The data with dronabinol alone on the AHI is sort of unimpressive. That was that one paper that David Carley did. Yeah. It showed a small effect, but not anything particularly substantial. So we'll see, but that's out there. I think that's a good bit further away because the study that was just published, each group had an N of about 8. Okay, 8 or 9 at each dose level, and the FDA required Apnimed, powered it up to do 650 per group for the pivotal, but even for the phase 2, they did 300. Okay. So that one's going to be a long time coming. But I'll go through that actual data, and I'll spend a good bit of time talking about the other carbonic anhydrase inhibitors that are out there, because ApneMed has acquired one of the companies that has a carbonic anhydrase inhibitor, and or at least they've licensed their technology, and that is probably more near term than Incanix is. So these, the carbonic anhydrase inhibitors alone.
Yeah, there was an announcement, wasn't there, that ApneMed had, I think, partnered or purchased or something, that company?
Yeah, I think they've licensed it
Okay.
from it was a company out of Europe. I think it was out of Gothenburg, that had been doing the work on the drug sulfime, which is a different carbonic anhydrase inhibitor than acetazolamide, which is more commonly used. But there have been meta-analysis with acetazolamide, and I'll go over that during the talk, that suggest some efficacy there. So that's probably one of the second line drugs that's out there. And particularly in line temporally. I mean, I think they're probably the second closest drug to getting to market if they, if everything goes well.
What else do you have?
I'm going to talk some about potassium channel antagonists. I mean, if you can block potassium channels, there's, particularly in the upper airway, we believe that afferent neurons in the upper airway that are mechanosensitive, these negative pressure neurons, if you can block the potassium channels on those afferent neurons, you ought to be able to turn up the negative pressure reflex in the upper airway, and it'd be a much more direct way of activating muscles than trying to do it sort of from brainstem down. This should activate the reflex peripherally. And so I'll go over sort of where that stands. There were two companies working on it. One was Bayer, the other originally was Sanofi. And both of them are out of the heat. They're not working on it anymore, but there's a company called Mosana that is now working on it. And I'll sort of go through what their plans are and how that's evolving. And if that works, that would be potentially virtually side effect free. Put a spray in each nostril, go to bed, and treat your sleep apnea. Because the systemic levels they would get with those agents are tiny, and because it's all working in the mucosa of the upper airway. So that's an interesting possibility.
That's kind of amazing. I was wondering when you said that it would be delivered peripherally. I was kind of wondering how that would work. So a spray.
It's hard to know because I'll go through with this, but some animal data suggests it works really well, and there's some human data suggesting that it has some potential as well. But the slight problem they've had with the other formulations where they were swallowed very quickly and they didn't stay in the upper airway very long, and that probably needs to be fixed. There are ways to do it. There's a whole world of people that deal with aerosol delivery of drugs, and they know everything about it and how you deal with viscosity and micro particles and things like that to get it to stay wherever you want it to. So that's a very exciting little area, because if that works again, it'll be a lot easier than administering some systemic medications.
I mean, it's kind of cool. Do you remember years ago there was like an insulin or something that they wanted to aerosolize? Do you remember that?
Oh, absolutely. Yeah, I know that went a long way. There were a number of companies working on that. I don't know why it failed, but it clearly did fail. In terms of it never came to market.
Yeah.
And I don't know whether that was side effect based or absorption based or whatever. But yeah, that seemed to be a better way. I think people would be more amenable to spraying something in their nose than they would, or inhaling it through their mouth, than they would, to do an injection. And so I think that was the logic behind it, but it apparently didn't work. But this one's different than that. In the case of insulin, you wanted it to be systemically absorbed and act on all the cells in terms of glucose uptake. This, you want it to only work in the upper airway.
Yeah.
You don't want it to get into the rest of the body because it won't have any effect there, and it could potentially have some side effects. Although all the side effects are pretty minimal, because one of the drugs at least was initially developed for atrial fibrillation. It didn't work very well for atrial fibrillation, but they were giving it, big doses systemically, and it had little to no side effects. And so, there's very little reason to believe it'll have side effects at the doses that would be absorbed systemically with just a nasal spray. So that's an exciting possibility. They got a ways to go, and we'll go over sort of how they're doing it. But that's an interesting one as well.
Well, that's a very cool idea. I love how innovative our field is, right?
Yeah, I mean, some of these things are coming from companies that are recognize that sleep apnea is a ubiquitous disorder that has what many people consider an inadequate therapy at this time. And if you could come up with something a lot easier, such as a pill or a nasal spray or something, that there would be, big rewards for that. And so that has attracted a fair amount of attention, which is certainly where these potassium channel antagonists came from. They came straight from the pharma world as opposed to the sleep world. On the other hand, 8109 came straight from the sleep world and then found its way to a pharmaceutical company. So there's some variability in all of that.
So if you kind of look in your crystal ball or read the tea leaves, do you think that we will be able to replace PAP with pharmacotherapy, or is this more hybrid, or what are your thoughts?
I don't think we're going to replace CPAP with the drugs. And here's the deal: drugs lead on average to a 50% reduction. Let's just say, and that's I'm just using 8109 as the example, and which means that some people get a bigger response than 50%, and some people get a smaller response than 50%. And so, the question is, and this is something I think we really struggle with: how big a response do you need to get to be satisfactory? Okay, what do you need to get somebody's AHI down to be satisfied? In my mind, that number is not 5, particularly if you're talking about hypopneas with a 3% or arousal definition. Sure. And that's just my opinion. But we don't really know from a cardiovascular point of view, and we don't really know, from a symptomatic point of view. It doesn't matter what it is if you clear up their symptoms. And so, if we could ever really understand what level do you need to get to for each person, it would help us, because if taking somebody from 35 to 15 is enough, then I think drugs will treat tons of people. If you've got to get people down to 5 or 10, it's probably not going to treat near as many people. I mean, as I said before, the 8109 top line data suggests that about 25% of the people will get down to an AHI 4, not 3 or 4, less than 5. And so then the question comes, what about all the others? And I think the sleep world, complains about the surgeons that use a definition of less than a 50% decrement and less than 20. Yeah. Sort of the magic numbers. And I don't know if that's the right answer either. But to really try to answer your question, I don't think they're going to replace CPAP. They're going to be people with sufficiently severe disease that drugs won't fix the problem. I mean, if you've got a terrible anatomy and require large amounts of muscle activity, my guess is that there are limits to what you're going to get with a drug. And so I don't think you're going to replace CPAP. But I think there are going to be a lot of people in whom these drugs work well enough that they become asymptomatic, and we're not, become less worried, if they're worried at all, about the cardiovascular consequences, and then end up, taking them satisfactorily. Again, we're going to have to see what the side effects are with 8109 or any other drugs, because if people don't feel better on the medication and it only leads to a 50% reduction in AHI, that's probably not satisfactory.
Yeah, agreed. I was chatting with Dr. Safwan Bader a few weeks ago, and he put this out there. He's like, you know what? We use polypharmacy for hypertension and for cholesterol, and why do we think that this is not an okay thing to do for sleep apnea? And so, of course, I've been thinking about this since that conversation, and I'm like, yeah, I mean, why don't we do polytherapy more often?
Yeah, no, and it's interesting because what we do now, everybody does. You try one thing.
Yeah.
If CPAP by itself will, virtually eliminate disordered breathing in everybody, and so if they like that, there's no reason to go further. But the question is, the other therapies rarely are completely successful.
Right.
And almost never do you. I don't think things like combining a mandibular advancing device with CPAP, in my opinion, has great merit. Because I mean, if the CPAP works, why would you want to also have to wear a mandibular advancing device? But combining, say, a positional device with with something that keeps you off your back with a mandibular advancing device would make a ton of sense. If 8109 only reduces your AHI by 50%, if you add to that a MAD, or you add to that a dental, prescriptional device or something like that. I mean, I think combining those things makes a lot of sense. It's just we haven't caught on to it. It's also going to be interesting what they charge for the drugs. I mean, if the drugs are, if they're exorbitantly expensive, you're not likely going to combine a drug with, say, Inspire, because if Inspire costs all in maybe 40, 50,000 bucks, and then you add a drug that costs $4,000 or $5,000 a year, and I'm just making up a number. I don't know what it's going to cost. It may get, prohibitively expensive. Although drugs prices are almost certainly what will come down from whatever they are initially, and so over time that may be more feasible. But I'm with you. I think we ought to combine agents. I mean, asthma, you do that in spades, COPD, hypertension, diabetes. And so we should do it too. It's just we hadn't had drugs, and combining devices is potentially a little harder than taking two pills. But I think the concept's totally valid.
See, and isn't it funny that you are not as excited about an oral appliance and CPAP, whereas I have a handful, so not a ton, of people who just couldn't tolerate the higher pressures. And so then combining it with a mandibular advancement device allowed us to treat them with lower pressures. So it's kind of funny, right? Everyone's different.
So yeah, exactly. And so you've had some success with that in a handful of patients. Yeah. I mean, I'm not saying it wouldn't work. It's just it's a pretty crowded face. You have all of that gear there in place, but if whatever works.
So what are you most looking forward to learning at Disruptors this year?
I guess I don't know all that's happening in the meeting. One thing that caught my eye was certainly Dennis Wong. He's going to talk about AI in sleep medicine, and he's a sort of an insightful guy. And I'll be interested to see, because he's tends to be very practical and wants to evolve things that move patient care along in a reasonable cost structure and things like that. So I'm looking forward to it. And I was going to also say I think this is an innovative idea that the AASM came up with, because they're trying to get people that are not necessarily sleep people, but yet venture capitalists and in the investment world, and potentially any entrepreneurial, to sort of hear about what's happening in the sleep world, and hopefully they can hear this stuff and lead to genuine efforts to implement methodologies to improve, the diagnosis and treatment of sleep disorders. So if it accomplishes that, I think that's a very worthy goal, and I hope we're successful.
Yeah, I always learn from Dennis. Whenever I see his name on any program, I know I'm in for a treat, and that I'm bound to learn something that I never would have figured out otherwise. So yeah, I agree with you. Well, thanks for sitting with us and giving us a sneak peek into your presentation at Sleep Medicine Disruptors.
My pleasure.
Let's take a short break, and when we come back, we'll talk more about the upcoming Sleep Medicine Disruptors course this November 14th and 15th in Austin, Texas. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with Steve Van Hout, the Executive Director of the AASM. He is telling us all about Sleep Medicine Disruptors. So we're excited to hear Dr. White's presentation on pharmacotherapy for obstructive sleep apnea. Steve, what are you most looking forward to?
I mean, there's a lot of really great sessions here at Disruptors. As I mentioned before, the two keynotes are going to be amazing. Really excited to hear their perspective and what they'll bring to the meeting. But we have a lot of great speakers who are really the top of the top. And that's David White, who you heard from, who's also a part of this podcast. Dennis Wong, who's just an amazing speaker, really on the forefront of integrating technology into practice. And David Kent is also amazing and somebody who's really forward thinking. So really excited to have our sleep medicine folk at Disruptors and speaking. But we have a number of outside speakers who aren't necessarily even involved in sleep medicine, but understand disruption occurring in healthcare. And one of those is Charlie Taylor, who is from the University of Texas. He's leading the Center for Computational Medicine there. and really is one of the experts in understanding how AI and machine learning can improve efficiency and accuracy in clinical medicine. So he's really going to bring a cool perspective about how AI is being used in medicine.
So, I was looking at the agenda and it seems like it's a little bit different than it has been before. So, have you learned something from past Disruptors meetings that maybe shaped this one?
I feel comfortable with change personally, so I like to change things up.
Fair enough.
And I don't want to have something that is predictable and is the same as it always was. So I like to challenge myself to say, well, what can we do differently? So definitely are trying new things at this year's Disruptors. And one of the cool things is having essentially a contest. So we created this Sleep Medicine Disruptors Innovation Award, which is really kind of a People's Choice Award. We allow different people and companies to essentially pitch an idea or pitch a product, and they submitted a whole bunch of nominations and how they thought they were disruptors. We then worked with a group of volunteers to kind of pare all that down, and we now have we have 8 entries into essentially a pitch contest that's going to occur during Disruptors. So we'll have four pitches for diagnostic type of innovations, and then 4 pitches for therapeutic innovations. So that's definitely going to make things more unique, because we will hear kind of that startup culture, that business culture of what can we do, and then they'll get feedback immediately from attendees, and we'll eventually crown a winner of both the diagnostic award and the therapeutic award. So really excited about that. We also have introduced abstracts, so we'll have some posters available, and then we'll also have a few oral presentations as well. So both of those are going to be new for Disruptors.
So, is a contest kind of like Shark Tank?
It's kind of. The sharks, I guess, would be the audience.
Okay.
So we're going to have it set up where the audience can vote in some way. And I guess I should have mentioned it earlier. Disruptors is both in person and virtual. So we'll have some people who are listening and watching virtually they'll be able to submit their vote as well. So
that's cool.
Yeah.
Like the early days of like American Idol.
There you go. This is Sleep Medicine Idol.
And remember when the first Disruptors was? That was pre-COVID. And it was super cool to have that live streamed.
Yeah,
that was a big project. Yeah, that was cool. That was in Chicago at that innovation tank or whatever that place
Matter.
was called.
Yeah,
it was cool. So I was looking at like some of the innovations, and I saw a lot on sleep apnea diagnosis and treatment, like you talked about. But I'm kind of wondering if they will delve into other like non-OSA sleep disorders.
The answer is yes.
Okay.
Yeah. So there's going to be stuff on cognitive behavioral therapy for insomnia. I think there's also some stuff on restless leg syndrome. I think we should get a wide spectrum of topics. So it isn't just entirely focused on OSA.
I feel like sometimes we're so caught up, right? We're running our clinic and we're seeing patients. And so I find like sometimes I have to be intentional about stepping back to to see the bigger picture. And so I kind of like it when like you've done the heavy lifting, right? Like I don't have to think about it necessarily. I just have to block off time and be like, all right, I need to go do this. And I'm kind of wondering, now that you've been at the helm for a while and you've seen these changes, like what do you think is coming for our field?
Well, I definitely think change is coming. But I would say that with pretty much everything that's happening now, especially with AI and how it's going to be more integrated in our day-to-day lives. So I definitely think people should not feel like jobs will be lost or anything like this. This is ultimately about doing things better, doing things more efficiently, which I think all these innovations are leading us towards. Generative AI allows us more easily be able to gather feedback or provide feedback or start to ideate a little bit more. AI, machine learning, I think is all going to have an impact, especially like during sleep studies, but also as we evaluate just patients in general. There's a lot of technologies coming that just lead to more personalized, precision-based medicine that will ultimately allow patients to be better treated and better cared for. So that's, I think, is the most exciting part of all of this is everything that you're doing, you should be able to do better and be more proud of what you're doing. Patients in the end are going to benefit from all of this.
Well, and I like how you kind of address the big fear, right? That like ChatGPT MD, like we've talked about Dr. Google for years, right? Mm-hmm. And so I think there is this sort of inherent, holy moly, am I going to be replaced? So I like how you've kind of addressed that, but you're also like, no, people still need to see people, right? But then how can we be more efficient? And is it more than just like an AI scribe, right? Like, are there innovations that will help us sort of extend beyond OSA even?
You're exactly right. All these, I really feel all these technologies in the end lead to efficiencies and just be able to do things better than you had before.
And I kind of like how you kind of split it up into diagnostics and treatment, right? Like David White was telling us about pharmacotherapy for sleep apnea, but it's really cool to see other, not only other non-OSA sleep disorders, but even other options for obstructive sleep apnea, right? To see different diagnostic paradigms for different sleep disorders. Like, this is kind of cool.
Yeah.
Is the goal then sort of a showcase of innovation that's already there, or by having this contest, are you trying to sort of spurn more innovation?
This is really to highlight the disruptors that are happening, the disruptive innovation that is occurring. We do have this idea of how can we create the disruptions ourselves. It's a side project of disruptors called change agents. And that is something that I really want to bring back at some point. I need to get the right spark, the right idea. So maybe you can help me with that.
I'm biased. We came in second when you did that, so I'm biased.
Yeah.
Let's do it again.
But no, this is really about highlighting the disruptors through the competition, and also hopefully be eye-opening to the attendees about just where things might be going.
You know what I kind of wonder too is I was speaking to somebody in clinic the other day who's had symptoms for like a decade, right? And never wanted to come in because he didn't want a sleep study, didn't want a CPAP. So I kind of love the idea that we are changing that a little bit, right? Like, people have this idea that you walk into a sleep center on one end and you leave with a CPAP on the other end without even considering these other treatment options, these other diagnostic options, and then these other non-sleep apnea related sleep disorders that maybe they would benefit from treatment. And so I like how it has taken it away from this sort of one diagnosis, one field, right? Because I think other people sometimes look at us as sleep apnea doctors. And I love that there's innovation in other things. And the idea of being able to offer more than PAP therapy or more than just sleep apnea diagnosis and treatment, right? To offer a non-pharmacological thing for restless leg syndrome, I saw something that's looking into Parkinson's, which I find really, really interesting. And then can we sort of marry our fields with other fields that hopefully we can be a bigger part of? We've talked about EEG fingerprinting, and can we identify people at risk of dementia and Alzheimer's earlier, and then really make change that is, potentially life-altering for a lot of people. So it's very exciting to me, our field.
Sleep medicine is in such a great place to expand in terms of its impact on your overall health. And to kind of see how maybe there's going to be some changes, innovations that can assist in other areas outside of sleep is very exciting. And I know you have maybe some consumer devices like a smartwatch or things that are starting to put things together. But I think you'll start to see more clinical focused products that kind of can connect some of these dots that go beyond sleep medicine.
Yeah, I actually love getting Apple Watches and stuff in clinic, because I think people are a little bit hesitant. They're like, well, I've been, my watch told me this, and they're sort of hesitant to share it with me. And I'm like, no, that's great. Like, let's look at it.
No, I love, my wife always gives me some grief over, she asked me how well I slept. And then I like, well, hold on, let me look at my watch real fast. And then I say,
cardinal sin. You know better than that.
Hey, it tells you.
You got to wait. You got to wait and see how you feel. And then you decide if you agree with it. You know that. Yeah. No, and it's funny because I think because like the big tech guys are talking about sleep, all of a sudden it's like normal, right? To talk about your sleep. And there's a million influencers teaching us how to sleep better. And, it's got legs.
100%. I mean, that's really one of the reasons we even started thinking about disruptors. I started thinking about disruptors is when you start seeing companies like Google, Apple, huge companies start to speak more about sleep and start to create products that have sleep components to it, they have enough money to really make waves.
Yeah.
And I wanted our members, Sleep AASM members, to really, I guess, feel more comfortable that this stuff is happening and understand that it's going to happen. I mean, they're not going to invest millions and millions and millions of dollars into this and then not do anything with it. So I continue to see a lot of commercial interest in sleep medicine in the field, and that's both in the consumer wearables as well as clinical devices.
Well, and to be fair too, it's not like they're pitting themselves against us, right? Because you've got like Matt Bianchi and Logan Schneider, right? Connor Hennigan, all these guys with tech that are fully immersed in sleep as well, right? They're part of our big tent of sleep medicine, and they're interested in collaboration, right? They're interested in
100%.
What we think, right? And I love that because it's not pitting us against each other, which sometimes I feel like, we spend a good part of the day sort of trying to explain why like mouth taping isn't right for everybody, right? So we're kind of battling social media a little bit. So it's nice to have tech a little bit more on our side, I feel like.
Yeah, I mean, that is something that was reassuring to me is when we have talked to some of these larger name companies, I won't name any names, but it has been my experience that there will be somebody with sleep medicine experience on the phone with us. So they know that, we know then that they really are taking it seriously, and they have someone typically board certified in sleep medicine who are on conversations with us.
Yeah, which is important, right?
They're taking it seriously.
Yeah, I agree. So any final thoughts for us?
No, I would encourage anyone who is interested in the future of sleep medicine, the future of healthcare, to attend Sleep Medicine Disruptors 2025. It's in Austin in November 14 through 15, but we also want it to be available to anyone regardless of where you're at. So we do have a live stream of the event. And as I said before, there will be some interactive elements to it. So you will be able to participate still in our award competition. And I think if you attend, you will be maybe surprised how much different it is than our other AASM events. It really is kind of the gloves come off, or we really are maybe it's more appropriate to say the tie comes off. We're a little bit more willing to try new things and experiment there. But it's a really fun event, and I'm really excited for it to happen. And I hope as many people can attend.
Hey, I live in Minnesota. You had me at Austin in November. I'm like, sold.
There you go.
Let's go.
Yeah.
Thanks for joining us today for this bonus episode and giving us a sneak peek into the upcoming Sleep Medicine Disruptors course, November 14th and 15th in Austin, Texas. Hope to see you all there either in person or virtually. Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.